Welcome to our channel. We are discussing last minute polls for NEET PG. We'll discuss rheumatology now. So rheumatology is basically autoimmune diseases. So coming to organ specific autoimmune diseases, think of myasthenia gravis. It is a blocking autoantibody against acetylcholine receptor. Whereas Graves' disease is a stimulating antibody against TSH receptor. So the mechanism will be different for both. The best screening test for SLE. SLE is one of the systemic autoimmune disease which can affect any organ. We have ANA is the best screening test, ANA immunofluorescence. But what are specific for SLE is anti-dsDNA and anti-SM. That is anti-double stranded DNA and anti-Smith antibody. We can have many other antibodies also in SLE. They are anti-Rho, anti-La. Anti-Rho, if it is present in SLE, it is associated with neonatal SLE and complete heart block in newborns. But actually anti-Rho and anti-La, that is SSA and SSB, are associated with Sjogren syndrome. The SS stands for Sjogren syndrome. So anti-Rho and anti-La are actually associated with the Sjogren syndrome. How will you diagnose Sjogren syndrome? Sjogren syndrome is also a systemic autoantibody disease where there is lymphocytic infiltration of many glands, especially the salivary glands. So presence of SSA or SSB positivity plus minus salivary gland biopsy or lip biopsy showing lymphocytic infiltration literally proves Sjogren syndrome. Now coming to another autoimmune disease, which is systemic sclerosis. Now another autoimmune disease is systemic sclerosis. It is of two types, limited systemic sclerosis and diffuse systemic sclerosis. Limited systemic sclerosis, there is anti-centromere antibody. Diffuse systemic sclerosis, there is anti-SCL70 antibody, also called as anti-topoisomerase 3. Now there is a disease called MCTD, mixed connective tissue disease, associated with anti-U1 RNP. Now there is a disease called as APLA, antiphospholipid antibody, which is an autoimmune disease affecting the coagulation system. We have three antibodies in antiphospholipid antibody syndrome. One is anticardiolipin, next is lupus anticoagulant, third is anti-beta-2 glycoprotein. So usually this APLA clinically will present as repeated pregnancy loss, or there is arterial or venous or small vessel thrombosis. So presence of any of these plus two of these antibodies will be significant. Antibody, we have to have 2 times positivity in 3 months. Crest syndrome is a subtype of, or it's one type of limited systemic sclerosis characterized by calcinosis cutis, which is calcification of the skin, Raynaud's phenomenon, which is distal vasoconstriction of the digital vessels, which can cause digital ulcers, esophageal dysmotility, which can lead to aspiration pneumonitis, sclerodactyly, also called as sausage fingers, telangiectasia, may be dilatation of vessels either in the skin, nails, or in the face. Now coming to joint involving autoimmune diseases, rheumatoid arthritis, the actual complete description will be it is an inflammatory polyarthritis. Inflammatory arthritis means there is early morning stiffness, pain on rest, which is relieved on activity. Polyarthritis is more than 3 joints, that is 4 or more joints involved. Rheumatoid arthritis affects small joints. Common joint effect is metacarpophalangeal and proximal interphalangeal joint. It should last more than 6 weeks. And the antibody which is positive here is RA or CCP. There can be ESR and CRP positivity. So the drugs used for RA, they are called as DMARDs. We have classical DMARDs and biological DMARDs. Biological DMARDs are the anti-TNF alpha inhibitors, interleukin-1 antagonist, etc. The classical DMARDs are hydroxychloroquine, sulfasalazine, methotrexate, leflunomide. Other points about rheumatoid arthritis is it is one disease which causes bilateral exudative pleural effusion. It causes bilateral exudative pleural effusion. Usually exudative pleural effusion will be unilateral. Rheumatoid arthritis causes bilateral exudative effusion, that too glucose will be very low. And it causes UIP pattern of interstitial lung disease in lungs. ILD, there are 2 types of pattern. One is UIP, that is universal interstitial pattern, or NSIP, non-specific interstitial pattern. Usually all autoimmune diseases will have NSIP pattern. except rheumatoid arthritis, which has UAP pattern. Now coming to the next joint disease, which is ankylosing spondylitis. The earliest feature of ankylosing spondylitis is sacroiliitis. It is detected by MRI spine. Previously, bamboo spine was the finding which was detected in X-ray lumbosacral spine, but that is a late feature. Earliest feature is sacroiliitis detected by MRI spine. This ankylosing spondylitis is a axial seronegative. Seronegative means we won't get antibody positivity here. So axial seronegative spondyloarthritis. Psoriatic arthritis is another spondyloarthritis which affects the appendicular skeleton. Here distal interphalangeal joint is affected. Rheumatoid arthritis, PIP is affected. Psoriatic arthritis, DIP is affected. Plus there can be nail dystrophic changes. If you see the criteria for psoriatic arthritis, there should be DIP involvement, plus there can be a personal history of psoriasis or past history of psoriasis or even a family history of psoriasis. The next seronegative arthritis is Reiter syndrome or reactive arthritis. Reiter syndrome is a triad of non-gonococcal urethritis, large joint oligoarthritis and conjunctivitis. So conjunctivitis, urethritis and large joint oligoarthritis. Now we will discuss about vasculitis, that is involvement of blood vessel. Vasculitis will be large vessel, medium vessel or small vessel vasculitis. So among large vessel vasculitis, we have giant cell arteritis. It affects males. It causes headache. The joint pain or systemic symptoms in giant cell arteritis is called as polymyalgia rheumatica. Takayasu arteritis is another large cell arteritis, large vessel arteritis. It involves the subclavian artery, so it is called as the pulseless disease. In Takayasu arteritis, what is not involved? Coronaries are not involved because it is coronary is only a medium to small vessel. Takayasu is a large vessel. Kawasaki disease is a medium vessel vasculitis. We have two medium vessel vasculitis, polyarteritis nodosa and Kawasaki disease. Kawasaki disease is important in pediatrics. We call that syndrome as MCLN, mucocutaneous lymph node syndrome, because mucosa is involved, skin changes like skin peeling are there, lymphadenopathy is there. Kawasaki is important because it causes coronary artery aneurysm even in pediatric age. Now about small vessel vasculitis. There are many small vessel vasculitis. What is important to know is the quasi-immune vasculitis, that is we have ANCA, that is anti-neutrophilic cytoplasmic antibody. These are specific antibodies which are found in diseases called as GPA, granulomatosis with polyangiitis, Vijayakumar granulomatosis. Vijayakumar granulomatosis. In that we have CANCA. Then we have another disease called as EGPA, eosinophilic granulomatosis with polyangiitis, also called as Church-Strauss syndrome. Here P-ANCA is present. So C-ANCA, P-ANCA vasculitis. Now other type of vasculitis is Behçet's disease. Behçet's disease is a vasculitis also called as oculo-orogenital syndrome. So the criteria here is there should be recurrent oral ulcers. How recurrent? 3 times in 1 year. So recurrent oral ulcers plus some other features. There may be eye lesions, genital ulcers, and it is called as positive Petherji test. Here the HLA-B51 is commonly involved. In ankylosing spondylitis, HLA-B27 is involved. Now coming to inflammatory myositis. In that dermatomyositis is very common, especially in pediatrics. The antibody involved in dermatomyositis is anti-MI2. Here there will be skin changes and muscle changes. Muscle changes is easy to understand. It is myositis, so there will be weakness of muscle. There will be proximal muscle weakness. Skin changes, we have many changes like Gottron papules, Gottron sign, heliotrope rash, V sign, shawl sign, etc. That is nothing but all the sun exposed areas will show violaceous rash. Now about crystal deposition arthritis, gout is very important. Gout is caused by crystals of monosodium urate. Uric acid doesn't deposit. A salt of uric acid, that is monosodium urate, gets deposited. Common joint is the first MTP joint or the great toe. So when you do a synovial fluid analysis, we can see the monosodium urate crystals, which are needle-shaped, negatively birefringent crystals. This will be in contrast to in pseudo-gout, where calcium phosphate gets deposited, where we can get envelope-shaped crystals. So envelope-shaped crystals are seen in pseudo-gout due to calcium phosphate or calcium oxalate deposition. So treatment of gout will be symptomatic management is by NSAIDs and colchicine. Colchicine is an anti-inflammatory drug. How will you treat the disease or the pathology changing drug will be drugs which reduce uric acid production, that is xanthine oxidase inhibitors, allopurinol and febuxostat. Also we have other drugs like probenecid, which excretes uric acid, and we have some uricase enzymes, RAS uricase, which are used especially in uric acid emergencies like rhabdomyolysis, hemolysis or tumor lysis. In these conditions, when cells go for lysis, the intracellular uric acid gets excreted. So to remove this excess amount of uric acid, we use RAS uricase.